Alrighty, everybody. So we have Dr. John Prpich here, who is John's amazing pulmonologist, and we're going to go ahead and have him introduce himself and give a little bit of a background on how he got started and his schooling and everything like that. So take it away, Dr. Prpich.
Sure. So my name is John Prpich, and I'm a pediatric pulmonologist, as Nicole said, here in Tampa, Florida, and I take care of baby John. I'm actually born and raised in Tampa, Florida, so I came back. I was actually born at the same hospital where John was born. So I think this is sort of like a whole sort of circle of life thing, right? Yeah. So born and raised in Tampa. I went off to college. I went to undergrad in New Orleans, and then I went to medical school in Chicago, where I was the first time I ever saw snow. So that I was a quick lesson in that I don't like snow. And so I came back down. I graduated medical school in 2001 and came back down to Florida, North Florida in Jacksonville for my residency. I did a fourth year of chief residency and then decided I wanted to do a fellowship, which at some point, if we want to talk about kind of how we decide and how, people decide they want to do pediatrics or fellowships or things like that, we can, but decided I wanted to do pediatric pulmonology and went up to Denver, Colorado, where I spent 3 years back in the snow, but it was a much nicer environment than Chicago was.
I bet.
And then came back to Tampa. So I've been in this job here in Tampa for almost 18 years now. It's saying I've only had one job. This has been it. I'm a pediatric pulmonary specialist doing what I do, which is also not typical for pediatric subspecialists. They tend to move around for different jobs in different academic settings. But I'm in a private practice, and I love what I do. So here I am.
Awesome. That's awesome. So you have a clinic here in Tampa. So you work out of, so we met Dr. Prpich when John was in the NICU towards the end of his NICU stay. And then he also works in the hospital setting as well. But then you have your private clinic if you want to explain how that works a little bit.
Sure. So we have a private practice that is just around the corner. Our main office is just around the corner from the Children's Hospital, which is St. Joseph's Children's Hospital, and the NICU where John was born is there, kind of attached to the Children's Hospital. And so we have our clinic time spent in our office, but we also have both consult services and inpatient services there at the Children's Hospital. So every morning I'm there rounding on patients that that we've admitted to our service overnight, and then I'm doing consults on patients in the hospital, and then also over in the neonatal ICU, which is where I met John and how I got involved. And then those kids that go home, specifically, a lot of the kids that go home from the Children's Hospital come to see us and follow up. And certainly the kids that come home from the NICU will see us in clinic for follow up.
Mm-hmm. Yeah. Is that normal? Is that how a lot of pulmonologists, they have like their own private clinic and then they work at the hospital as well? Or is it normally they're just in the hospital? I don't know. 'Cause all I know is you.
Right. So yeah, I mean, I think just in terms of that sort of setup, having, inpatients and consultative services, and then having a outpatient clinic time that's pretty typical for pediatric specialists. And just in case anyone has interacted with adult pulmonary, we're in the pediatric world, we're very different. So our pediatric pulmonary fellowship is really just primary pediatric pulmonology. In the adult world, it's a combined. So the adult pulmonologists are also they're also the ICU doctors. But in the pediatric world, right, it's a totally separate or a kind of a combined fellowship. So the adult ICU doctors are the pulmonologists. And so some of the adult pulmonologists do clinic, but a lot of them spend only, their time in clinic versus, like I said, in the pediatric world, it's all we do is sort of hospital and consults, and then a kind of time in clinic. Where we're different is that, like I said, we're private practice. So a large number of pediatric subspecialists and a large number of pediatric pulmonologists are in academic centers, right? So they're in large centers like University of Colorado or like University of Florida, and so they still have clinic space, but that clinic space is often located within the hospital, like maybe in a medical arts building, or sort of attached there, kind of to the Children's Hospital. There's a lot of gray sort of area in between a full academic center like a University of Colorado or a University of Florida, or someplace that has university in its name, and then what we are, which is really private practice, right? We own our practice. Mm-hmm. There's a lot of ways that sort of pediatric pulmonology can look in between. They can be owned by a hospital. They can be owned by kind of a multi-specialty group. They can be, part of a sort of a sort of other ways that it can look. But I would say that what we are and the university sort of set up are the two extremes with different ways they can look in between. And the main reason why I've sort of looked into this is because actually I'm getting ready to do a talk at American Thoracic Society, which is it's like our largest meeting. And I'm doing a pro-con with one of my friends who's an academic pulmonologist, pediatric pulmonologist. And we're going to talk about the pros and cons between private practice and the academic life. Because our lives are different, but not maybe as different as some of the fellows that are going through training may think.
Okay. That's interesting, that whole subject. I've always wondered about that because obviously I know a lot of moms with BPD babies. And so whenever we talk about pulmonologists, the whole dynamic is so different across the board of where they see their pulmonologists, how involved their pulmonologists are, which is a topic we'll get to, is that they're also different across the board, pulmonologists, pediatric pulmonologists, which is pretty cool, but it's also super confusing for all of us when we get together. All of us moms, we're like, why is everybody on different pages? But also the other thing we'll get to is these kids are also different. Like no case is the same, which is what's crazy about BPD is there's a lot of similarities in all the cases, but everyone is just so significantly different. So let's talk about why did you want to get into pediatric pulmonology? Because it's such a specific specialty and it's not as common. So let's hear about why. What made you want to do it?
Yeah. So I think one of the things that I think people don't realize is when we all start off in medical school and we think we know what we want to be, but we don't really know, right? We all start off doing those same 4 years, the same clinical rotations, a couple of months in pediatrics, a couple of months in surgery and internal medicine. And it really isn't until you like when I started, I thought I was going to be an adult cardiologist because my father worked for a pharmaceutical company and I was just exposed to a lot of adult cardiology stuff. And in third grade, we had a talent show and I did a lecture on cardiovascular blood supply in my elementary grade. So I was a dork from the very beginning.
For a talent show? Oh,
for a talent, yeah. Some kids sang and danced. This was because I'm old, right? I'm going to be 50 this year, so we didn't have PowerPoint or anything back then. I had a flipboard and a pointer, and I had memorized what I was going to talk about. But I knew I wanted to do medicine from very early on. But I didn't know, right? So you get into med school and then you do these rotations and then you quickly kind of realize what you usually realize what you don't like first, right? So I started off doing internal medicine and realized I hated taking care of adults. I was, not that I was angry, but I don't know, I was not driven to, I just was a miserable kind of rotation. And then I did my first pediatrics rotation and I loved it. I love taking care of kids. I love families, even if they're stressful, even if they're it's a hard time. I was never angry at the patients. It was never their fault, no matter what the clinical scenario was. So I quickly realized I love pediatrics and that was as far as I thought. So I move into my pediatric residency and I loved taking care of kids, but I realized that primary care was not really where my heart lied. It was, I'm in clinic talking to moms and we're having these in-depth conversations about, should I use a binky? When do I take it away? Do I spank? And those were important conversations, but at the time I didn't have any children. I wasn't married and this wasn't who I was. I wanted to take care of sicker kids, but I enjoyed continuity. I enjoyed getting to know families, right? I enjoyed following over time. So I knew like emergency room wasn't going to be for me. I knew, the ICU, you get to know the family for some, point, for, some period of time, but not that long-term follow-up. So I was sort of searching, trying to find, something that provided that continuity, but still the acuity, the kind of clinical, medicine that I really liked. And then I just fell in love with pulmonary, the physics, the physiology, the way we think about airflows and all that just made sense to me. But it took, a little bit because once again, it's only about what you're exposed to. And in Jacksonville at the time, we only had 2 pediatric pulmonologists in that department there in the Moores. And so we had a little bit of exposure, but it wasn't a really robust exposure. And so it took me a while. And so I did an extra year as a chief resident, mainly because I was trying to sort of find my way, and I realized I want to do pulmonary, but I needed an extra year to apply to fellowship. So that was, but that was it. But it's a process, right? Of kind of finding your way in terms of what you want to do. And then I loved it, and then went off to Denver, and it was amazing. And got my first real exposure to a big department, right? Denver, right now has about 32 pediatric pulmonologists in their department. It's massive. I know. So you think, you're still hearing about people doing things differently. You should try even within the same department.
Wow.
Yeah. So, although one of my friends, he was a fellow with me in fellowship. His name is Chris Baker, and he's in charge of their mechanical ventilator program and their whole program up there in Denver. So it was a really neat experience being exposed to all of that, just to those different ways of thinking about things, and also the cool thing about Colorado was everything came to the Children's Hospital. There's nothing else in Colorado, in Wyoming, in Montana. And I mean, the amount and variety of complexity is really, it's a neat experience for sure.
I didn't even think about that. Denver is really, I mean, that's it. That's your hub for that entire area. Your major hub. I didn't even think about that.
Absolutely. So it's nothing for, to hear these kids have to come in via fixed wing airplane and then fly. I mean, it's really for complicated kids. I mean, there's nothing else in multiple states.
Did the altitude, I mean, this is such a Floridian question, but did the altitude affect any of those cases more? Like if they were born down here or dealt with down here from the beginning, would it have been easier for some of these kids, or they just adjusted to it right away? Does that play a role in it?
It does. I mean, I think our concept, a little bit of what we accept for oxygen saturations were a little bit different in Denver. And certainly when people would visit Denver, one of the interesting, there's a pattern of respiration called periodic breathing that infants, and certainly even infants in the NICU, will do, where and when they're asleep, they'll have these repetitive periods where they'll breathe, pause, breathe, pause. And it's a normal newborn breathing pattern, but then as you get older, it kind of goes away. But when you go to altitude, it will come out. And at altitude, kids would actually desaturate. They would have blue spells. And so we would have all these kids that would get admitted for these kind of apneic episodes. And it was all just altitude and being in Denver and having that periodic breathing. So we would see tons of those kids on a regular basis. But yeah, I mean, it definitely impacts what we consider for normal saturations. It would impact even some of the discharge criteria, even for normal kids. Like nowhere else really in the US do we send kids home with bronchiolitis, right? With viral bronchiolitis on oxygen. Our goal is to get them off the oxygen before they go home. But in Denver, some of these kids, if you don't send them home with oxygen, they're stuck in the hospital for another 2 weeks. So they were more aggressive or more accepting of sending some kids home with just viral bronchiolitis with oxygen, just to get them home, So yeah, it changes sort of the way you look at patients a little bit, for sure. But the same thing, I was a Florida person, so it was very new for me.
Yeah. Okay. I'm like, we are literally at sea level, so no idea what that's like. I've been to Colorado once. It was in the summertime. Like you, I didn't see snow till I think I was 23, 22. I saw snow for the first time in Germany, and it was like May. We went up a mountain in the Bavarian Alps, and I was like, this is snow? Like, gosh, Florida, born and bred, Tampa. So
absolutely.
So funny. Right? All right. So let's go ahead and get into, let's go talk about, so you at our hospital didn't get involved with John until he was much older, and we were kind of talking about next steps for him. For a while, John was looking like he was going to avoid the trach. He was doing great. He was on bubble CPAP and taking bottles and stuff like that, but we ended up finding out that he was silently aspirating. He was also on like a 42-day steroid low dose course, and once we tapered those off, mixed with the silent aspiration, he just slowly and then declined over like 2 weeks, and then all of a sudden suddenly declined. Because we met, and when we first met, I was very anti-trach, this doctor came in, and I was like, he's going to come in here and just tell me that he needs a trach. And shockingly, you were not, which was great, which I very much appreciate, because if you're a trach parent, you know that like a lot of these doctors just make it like it's nothing, and they walk in, they're like, oh, it needs a trach, it's really simple, you can go home with it. And it's like, no, it's
Right.
not. I mean,
It's a
eventually
big decision.
it becomes like second nature, but I can't
Yep.
stand when doctors make it out to be nothing. But he came
Right.
in and he was very understanding that we were trying to avoid it as much as possible. We really wanted to try to just get him to high flow, and we weren't in a rush to go home. We just wanted him, to get to where he was stable and come home when he was ready without a trach. And then
Right.
a couple of days later after we met, he just declined, and they reintubated him, and we were like, all right, please give him the trach. And so it's kind of funny how our conversations changed within a week and a half. But you typically don't work with like micropreemies when they're first born. Like you don't work in the NICU with that. You work when they're older and they're either going to get
Mm-hmm.
trached or they're very much established BPDers where they're going to follow up with you once they're discharged, right? Is that how you kind of
Yeah.
start that process?
Yeah, no, it is. It's usually we get involved when it's a little bit later. There's not, I mean, there's not an exact gestational age or time course when they get us involved, other than if we're either going to be having discussions about, tracheostomy placement, or in your case where we were trying to decide, right? I mean, it is a hard decision to make sometimes, because you're right. It's a big decision. I'm not a fan of it being something where you just walk in, like you said, just drop the mic, say, baby needs a trach, because we think it's a big decision, but I mean, it's a much bigger decision for the parents. And at the time, and I'd say it, I don't know if you remember me saying to you, like, I know it seems overwhelming now when you're on the other side, and when you've got, you're going to look back and say, it's not as big of a deal as I thought, but that's also with a whole lot of experience and training and teaching and life under your belt.
Yeah.
And so it's important to not, even though we know that it's something that you'll handle, it's something that you'll deal with, it's something that you will do great at, but you don't know that at the time. And so you have to be aware that this is a really big decision. And so making it last minute or feeling like you're being rushed and pushed into it is not the way to do it. It's got to be a discussion. And to some sense, sometimes they'll say the baby will tell us,
Yes.
and I think one of the things that, and you saw this with him that early, is we're trying to be as patient as we can, with the baby. And so if it is just waiting another 3 weeks or 4 weeks or 6 weeks, sometimes we get pressure from different areas of the hospital, different components, whether that might be nursing, whether there might be other people within the NICU, or even if we're in the pediatric ICU, right? We're getting pressure because it's almost, they see it as the short way out, but that's not the right way, because if you really are 3 weeks or 4 weeks away, it's better to wait, right? But when you cross that line, right? When the baby gets intubated again, when you're at that point where it's becoming, as you weigh that risks and benefits, it's becoming riskier, to not have the trach in place, right? You're starting to see that it's not as, because you usually it's the experience that you guys have. Well, sometimes they're really severe and they never get extubated, and then it's an easier decision, right?
Correct.
But when you are able to walk that walk where you get at least the beginning of seeing what life is like without the medicines and the sedation that goes along with being intubated, right? When you are able to at least sort of interact more in a more meaningful way with your baby, and then you that step back where you end up reintubated, then that's when it becomes, I think, more palpable. Like you saw, like, okay, I want my baby back, and I don't want to go down this road of being intubated with sedation and paralytics again for a prolonged period of time, right?
Well, we had gone exactly. So when he was extubated for so long, we had been able to pick him up and move him around much easier and experience that. And so once he was intubated again, and he was so uncomfortable because he was a much bigger baby, and no offense to the NICU, they're not the best at, sedating their kids, because they don't do that a lot when they're much younger, which I understand. But he was a big boy, and you couldn't keep a line in him either. And so he was wide awake, miserable, intubated, had experience being extubated. And so we literally went from being like, screw the trach, we don't want the trach, don't come near us with that talk, to 48 hours later being like, can you schedule it for tomorrow? Like, please. So it makes a
Right.
huge difference. But then you also see those cases where I feel like it depends on the medical team, but like
Mm-hmm.
sometimes I feel like people get the trach way too early, and then they end up going
Mm-hmm.
home like already sprinting or off of the vent, and it's like, well,
Mm-hmm.
you could have probably just waited another couple months and then gone home with just oxygen. And so I
Yep.
sometimes I get frustrated with that because we had one NICU doctor, Dr.
Mm-hmm.
Ravenstein, who I love,
Mm-hmm.
and this was when John was like looking like he wasn't going to need it when he was first
Mm-hmm.
extubated and handling it well. And we just kind of said to him, because many of the other NICU doctors like were very much like, oh, no biggie, he'll just get a trach, like no biggie. And we're like, no biggie, like. But he came
Yep.
in one day and he was like, no, if you don't 100% need a trach, like it's an open
Yep.
airway. It's like, why would you have that for no reason?
Right.
Why would it can cause more issues if you don't actually need it? And it's not as simple as a recovery as some of these people make it out to be. And it was really refreshing to have a doctor come in and like make us feel like we weren't crazy for feeling that way. And then when you came in and you like agreed with me and you weren't like being forceful, it was like refreshing. And then it made me feel more comfortable with the decision, because I felt like we were not
Yeah.
being forced to it. But like you said, a lot of the times the kids will tell you. And I always was like, I wish I had a
Right.
sign. Like I was just like praying, like, God, give me a sign, because
Right.
it's weird when you're in that, like when you have a decision to make. It's not
Mm-hmm.
like he's laying there intubated and you have no other option. Like we had a decision to make for a couple weeks, and
Right.
eventually he got reintubated and he looked at me and I was like, oh, he's telling me. He's telling me. So
It's time. It's time.
yeah, it made it easier. And now I'm so grateful for the trach. It's been a road, which you are fully aware of. We always say everybody has John PTSD on his medical team, because
Oh.
baby John has put us all through the ringer, but he's come really far. And he's really come a long way. So the trach was the best decision, but I don't regret for 1 second pushing it off. Like I think I'm
Right.
glad that we did everything we possibly could to avoid it, so that we never second guessed
Right.
it.
And 100%, right. And I'll say that to parents too, that if it's and sometimes I have to push back a little bit on maybe the ICU team or even the nursing team, or a little bit. I'm like, look, like we need the parents to feel as confident as they can about this decision. And if that's one more attempt to extubate, if that's one more period without, or one more reintubation, but then that's what the family needs, and that's what the family needs. And that's a really important part. And I think just for people that are listening, because, these decisions and the timeline for these decisions can be also very regional, right? It's going to depend on what the resources are in your community. In some places where it might be a NICU that doesn't have as much availability in a children's hospital to sit and watch them for a longer period, versus, there's places like nationwide that have really, robust, almost envious of, resources for families to sit and for children to sit for very long periods of time, in sort of step down situations. Because we have to be honest. I mean, we get pressure from a hospital, we get pressure from just the cost of what being in an ICU setting is versus being in a step down setting, and that's the reality, and we try not to let it cloud our decisions, but we get pressure. And so in certain areas where there are certain hospitals where they have carved out step down areas where they can allow somebody to sit on nasal CPAP, allow someone to sit on, even certain levels of high flow for months. That's a nice kind of situation. But like you saw, I mean, even with those things, with the CPAP, and it's all about the child and what their developmental needs and what the parents' needs are at the time. And so it's not a cookie cutter decision at all. I mean, it's very individual for each patient, in terms of making the right decision and with the family together kind of as a team.
Yeah. I mean, exactly. I mean, like, I have one of my friends brings her twins. Well, I think only one of them
Mm-hmm.
to you, which, I mean, with HIPAA, I guess probably can't get into it. But anyway,
Right.
the one baby, they were at a different hospital and they were very much pushing to trach this child. And the family was like very adamant, no, like give her time, she can do it. And she went home with like no oxygen. She's off oxygen. She's so healthy and doing great. And, she's one of those ones that it would have been a mistake to trach, but that's the medical people just pushing it. And they were even like, oh, she could probably go home, like, and start sprinting right away. And it's like, well, why do the trach? And that's a perfect example of it.
Right.
And then it's hard sometimes in certain hospital settings. If you push back too hard, then you can cause different issues you can make certain medical providers upset, which is a shame, but it happens. Egos are hurt and stuff like that. So I just always say, gosh, I'm so grateful we were at the hospital we were at and we had John's medical team, because they were just all God sent. So, all right, let's talk about BPD. So bronchial pulmonary dysplasia. I basically have this one topic, BPD for Dummies. So if you want to just kind of give a quick overview of what that is for those who are listening and don't know, it's basically what chronic lung disease is, kind of the easy way, but it's what John has. My John. Sorry, it's confusing. When I say John, I'm going to talk about my little John. Okay, go ahead, Dr. Prpich.
Yes. That's okay. No, I know, right? It's a pretty common name, but it's a good name. It's a good, strong name, so we like it.
Yes.
But right, so bronchopulmonary dysplasia it's a type of chronic lung disease. I think if you think, and we do this in medicine, right? We put things in certain buckets. The term sort of chronic lung disease and chronic lung disease of prematurity would be the largest, most expansive sort of bucket. That's really where everyone really going home from the NICU, whether they're on oxygen, really honestly, even if they're going home on room air, but they were on oxygen for a period of time, a significant period of time, they get put in that bucket. And part of why these buckets exist is so that we can study and so we can learn outcomes and we can learn impact of intervention. So that chronic lung disease of prematurity is the largest bucket. Underneath that bucket, is a subset of children that we call bronchopulmonary dysplasia. And that definition of what we call BPD and how we think about BPD really has changed over the years, right? I mean, it was really first described back in the 60s and 70s, and believe it or not, so that term back then was given to babies with very significant lung disease that were born at 36 weeks gestation. I mean, really almost what you would consider term and go to the newborn nursery now. But we've learned a lot about lung development and how to manage these children. So right, I mean, they wouldn't have even dreamed of having a baby born at 23 or 24 weeks. And so we've learned it. And a big part, so kind of stepping back, I think one thing that maybe is helpful, and hopefully I don't geek out too much, but understanding just a little bit of what happens in babies that are born premature is without going into too much detail, understanding kind of lung development, right? And one of the things I tell families is even if you're born full term, which is 40 weeks, even if you're born full term, there's an entire last stage of lung development that happens after you're born, which people don't think about, but it's intuitive, because if we had to live with the same size lungs that we're born with, we'd have problems, right? You wouldn't have any high performance athletes because we'd all have these little tiny lungs. And it's not so much that they just grow in size, right? We have to add to the complexity. We have to add millions and millions of these little air sacs. We call them alveoli. And so I use this analogy of the lungs like a big upside down tree. We've got the trachea, then we branch to the right, we branch to the left, and we've got 3 lobes on the right and 2 on the left, and we branch 23 times. And then at the end of those branches, like you see in a tree, are leaves, millions and millions and millions of leaves. And like a leaf, right, if you hold a leaf up to the sun, you see those little veins, the little sort of leaf veins running through that very thin layer of the leaf. And that's what these alveoli, these sacs, are air sacs that are really very thin walled. In some spots, they're only 1 cell layer thick. So they're very delicate. And the blood vessels that pick up the oxygen are running through that very delicate sort of sac-like structure called the alveoli. And that's how we pick up oxygen, right? So we breathe in, we inspire oxygen. The oxygen gets down into those little sacs, and then it just passively diffuses into those blood vessels. And so you can understand, I mean, that the reason why these leaves, when you step back and you see a tree, it's huge, but it's huge because these leaves are stacked on top of each other. It's all this really small kind of structure making this huge thing. It's the same thing with the human lung, right? So an adult lung has half a tennis court of surface area laid out kind of in front of you. So it's a huge surface area to get all this oxygen into the bloodstream.
Wow.
And so when they're born, it's a huge surface area.
Yeah.
So when we're born at 23 weeks, 24 weeks, we're just moving out of where these airways have started branching, right? really have rudimentary gas exchange units. We're starting to have these kind of little areas, but we don't even have formal alveoli yet. And so that's really, we're down to 22 weeks, 23 weeks is about the earliest that we're able to, kind of support in the NICU. And until some really dramatic change in technology comes along that I can't even envision, that's really where that line is, mainly because that's where the physiology, we need at least some place for oxygen to get in, to the bloodstream, unless we go on some kind of heart-lung bypass. And so what we're doing when you're born that early is the growth and development of the lung is essentially put on pause, or at least slowed down significantly, because so much of the factors and growth factors and drive and signals for lung development come from the amniotic fluid and being in mom's belly. And so these babies that are born so early really are, really have a very, almost like I said, no alveoli. And so now we're doing this slow kind of growth to add back to those gas exchange units. But that process takes a long time. Because like I said, even if you're born full term, it's years where you're adding on to the number of alveoli, and then even more years where you're adding to the size. So it's a simplification. Sometimes I'll say, imagine it's a tree, but with a whole lot less leaves. Right? Like a tree in winter. The leaves aren't gone, but there's not very many leaves. And that's what we're working. And so really we're supporting this growing and developing lung, and we're trying to do it in a way that doesn't damage. And that was what we've learned from, like I said, back in the 60s when they first described, was so much about learning how to support that growing lung, and what that growing lung needs changes over time in terms of how much ventilator support, what's a normal oxygen saturation, how, can oxygen damage it at that early of an age? Yes. And so we've learned so much about those approaches. But then the biggest thing happened in the 80s when we developed something called surfactant. And so surfactant it's a detergent. So I talked about all these millions of alveoli. The problem is if you leave those alveoli on their own, they collapse because they're so small, and the surface tension, they'll just collapse. So surfactant is a chemical that the lung, some of those cells in those alveoli secrete to drop the surface tension so the alveoli can stay expanded. And until we were able to give that surfactant, that's where so much of the damage that we saw with what we call old BPD. So there's this concept of old BPD and new BPD. Okay. And really the line in the sand is when we started developing surfactant and using surfactant, so that now those alveoli, those air sacs, could stay open easier, so we didn't cause damage with our ventilators as we were providing in the oxygen in and out, right? So that surfactant was the development of surfactants, a huge line in sort of our management of BPD. And so then really it's just been incrementally us learning more and more about ways to gently support the baby and support the lungs without causing damage or trauma over time. And then those needs change. So the way that we manage a ventilator in that, very early on is very different than when I met you guys and when we walk in, and then even now how we manage the ventilator. So it's this idea of BPD really is a simplification because of when the baby is born. Now there's other factors that play a role, nutritional factors, infection in the NICU, like I said, oxidative damage from oxygen. And then the one other piece that about half of our babies will struggle with is something we call pulmonary hypertension. So I talked about those leaves and those veins like you see, right? Those are the blood vessels. Well, like a blood vessel, they have muscle in the walls of those blood vessels that are in the alveoli. And like we talk about, high blood pressure in your body, right? Those vessels, same thing. Those blood vessels that are running, through those really thin-walled alveoli can have high blood pressure. They can either because the muscles themselves, or because because those muscles get thickened, or because the muscles are squeezing, and that makes it hard for the heart. Because the heart has to push essentially there's, the same amount of blood volume that goes out to your body has to go into your lungs, because it's a cycle, right? So if that right side of the heart, which is kind of the wimpy side of the heart, has to push against this high blood pressure, that's a problem. And so a lot of our kids, because if you imagine, even though we're born, early, we still have that same blood volume, but now we're having to push that blood volume through that simplified tree. right?
Mm-hmm.
So less leaves, less surface area, more pressure. So that can be a reason. Infection, inflammation, irritation. We don't, there's multiple factors that play a role in the development of pulmonary hypertension, but that's a big challenge. And that was, I don't know if you noticed, like John would get echocardiograms every month to look for any sign, right?
Yeah.
Any sign of that pulmonary hypertension. And about half of our kids will struggle with that pulmonary hypertension. But they thankfully, as we add to the number of the alveoli and as we add to those leaves over time, it becomes less of a problem. Sometimes not, but often it does. And they outgrow it.
Yeah, he never had pulmonary hypertension, which when we went over to the PICU, they were all like, "Are you sure?" Because his settings were so high, and then is it typical that typically these BPD kids that are especially trached and on significantly high vent settings are more likely to have pulmonary hypertension, right? I mean,
they can. I mean, I think the pulmonary hypertension, it's tied into it. It just depends on why we're on such high ventilator settings also, right? I think now in retrospect with John so much, his airway malacia, which there's a whole nother part I'm sure that we'll talk about, played a big role in terms of why he was on the settings that he was. I think the other piece, and this definitely applies to John and really all of our kids, is also the recognition that when they're first born, it's this very simplified lung that's a little more uniform. As they grow, their lung disease is not uniform. So there's certain areas of the lung that are what we call very high compliance. They're very easily distended when we add in, when the ventilator sends that breath, and other areas that are much stiffer. So the analogy I use is like those little squeezy toys the kids have, where when you squeeze them, some little bubbles pop out bigger than other bubbles. That's the way that the BPD lung is. One of the kind of hallmarks is that the lung disease is very, what we say, heterogeneous. And so that makes it hard because the ventilator is only treating the lung like one unit. The ventilator is not smart. And so it's going to send the same size breaths. And so if there's areas that are very easy to distend, it's going to send more of the breath to that part of the lung and less to the areas that are stiffer. And so that's that balancing act as we pick sort of settings. But it can make it hard because sometimes if there's a lot of stiffness to the lung, we end up with high pressures, as we're trying to get the whole lung expanded. And that's down at the alveoli, down at those air sacs. Then you fold in what the airways are doing, right? The trunk and the proximal airways in terms of are they collapsing because the cartilage is soft, and then you add in the malacia, and it's a balancing act.
Yeah, he had, when he was a couple months old, he was super sick, and he was 100% oxygen, maxed out on jet ventilator, like the highest settings they possibly could go. And I remember he had like one section on his left side that it was like black, but it wasn't like air in it. It was like just not, it was just like not even working. I forget what the term they had for it, but he had
Aerodigestive.
Exactly. Yep. Yeah. So, yep. And it would not open. And that was like one of our biggest issues too. And eventually it cleared up, but like you said, I feel like when they're born, it's more simple than as he got older. It was just like the x-rays would look even crazier and crazier. And isn't it also too, it's a catch-22 is like the name of the game in the NICU. Everything's a catch-22. And so
everything has a cost.
Everything. And so like back in the day, right, isn't it true that Stevie Wonder is blind because he was like a preemie, and back then they didn't know that? I thought this was true. They told me this in the NICU that he's blind.
I gotta Google it. Yeah.
He was a preemie, and they had him on like, back then they thought 100% oxygen is not going to affect you. They would just give you oxygen, and that's why he has vision issues. Well, let's just go with that story. So whatever.
I like it.
And so, so if you're on a lot of oxygen, it can affect your child's vision later on. So they were always very careful about that. But then also being on such significantly high vent settings for such a tiny little baby can just damage the lungs even more. But then you also need it to keep them alive. So like he was on a PEEP of 18 when he was 2 pounds. And they were telling us like that they hadn't seen a kid that high in a very long time in the NICU. And we had this talk when he was reintubated, and then after he got his trach surgery, he was really struggling. And later on, we found out it was Malaysia, but they had put him back up to PEEP 16 and PEEP 18, and Dr. Prpich and all the other PICU doctors are like not that concerned about it. And my husband and I were like fight or flight panic mode. Like last time he was on a PEEP 18, they told us he was going to die in a couple hours. And they're like, these are two different babies now. Like it's significantly different when you're 2 pounds versus you're 13 or 14 pounds. So why is that? Just the size of the lungs, like right at that time, or?
So yeah, and the somewhat also the development, right? So we know that earlier when we're still that early stages where we're really still just trying to develop those early alveoli, that's where the oxygen toxicity is a bigger deal, both for the eyes, but also for the airways and for the alveoli. But that's also where the pressures are more damaging. We call it barotrauma. So and that's why sometimes you'll see the jet ventilators or the oscillator kind of ventilators. It's about pressure, but it's also about changes in pressure. So what we try to avoid early is also these big shifts where they're getting really expanded and then slamming shut, and then really expanded and slamming shut, because such a delicate part of that development. As we get older and we start to get some fibrosis and scarring, but we also get those areas that are a little bit more compliant, but we also get further in where that the damage that the oxygen may play becomes much less, and the damage that pressure and those changes become less. We're always aware of it, but it becomes much less of a drive. And certainly as we get closer to term, we don't worry about oxygen, right? That's why even like the kids with just chronic lung disease, we'll send them home on half a liter of 100% FiO2, where if we had somebody early, I mean, that would be, could be much more damaging, right? So, but you're right. That was part of that learning process, since early and those early BPD kids. And early chronic lung disease till now, but everything has a cost, and it's a process of learning what the cost and how that cost changes as the child develops and as the child gets older, right? But right, we've also learned that in some of these kids, because malacia, to some degree, whether it's tracheomalacia, and just for if there's anyone listening, when we say the word malacia, we mean softening or sort of collapsibility of airways. It can be in we can have collapse in the larynx, the voice box. So we say laryngomalacia. We can have collapse and softening in the main airway, the trachea, that's tracheomalacia. And then you can have softening and collapse in the lower airways, the bronchi, so that's bronchomalacia. And all kids with BPD and all their preemies to some degree have some malacia. It's just like always, it's a spectrum, and to what degree is it causing some challenges? And so often we'll use that PEEP, like you talked about, those high levels of PEEP to try to stent open those airways because of malacia. We're sort of blessed, and John certainly is blessed, because we have that one pediatric surgeon that does that procedure, that tracheopexy, and he does the most in the country. And that whole experience was so eye-opening, because we've gotten accustomed to just dealing with the malacia, and I still struggle with who needs the tracheopexy and who doesn't. I mean, John would try to poop and die. He would have these horrible spells, and so it was really something had to change, something had to give, right? But I'll be honest, this is me being honest, I would not have predicted how important that procedure was going to be in terms of helping him in the way that it did. I mean, it was.
Yeah, I don't think anybody did. I mean, I really think we all just thought. I mean, his lungs are awful, and they're going to be awful. He's a 23-weeker, but we all just thought it was lungs, and for backstory, John, if you're not familiar with me, John is the happiest child you'll ever meet. And Dr. Prpich would come in and do these PEEP studies in the room, which is a live, like almost like a bronch, right? And so he'd put this camera down John's trach, have a big screen TV in the room, and there'd be like 20 people in the room watching it. Everybody was there. And John loves people. And so John was happy when everyone was in the room, and he'd, cough a little bit, but like nothing drastic. So when we would do these PEEP studies, he had malacia, like Dr. Prpich said, all of these babies do, but it would pop back open. It would collapse, but he'd pop right back open. And it was nothing of like a concern. We thought his trach was long enough. We messed with his settings. We did go up a little bit on his settings and saw that did help some, which when we say settings, we mean his PEEP. And then a couple months later, I think we did another PEEP study and kind of, saw the same. It looked better. Like his collapse looked better. But with John, which was something the PICU doctors were super perplexed about as well, is typically these kids will usually have like an episode, right? Like it's kind of, they always say it's like par for the course. They get to have one bad spell and then they get it out of their system and they're done. That's what they always told me. So when he had his first code, they were like, one and done. He's good. Like it happens. It's okay. But then he kept having them, especially he had two at home, which was terrifying. And like, also I can talk about that. Like, I think I pushed way too hard to bring him home, but like, you live and you learn. Like we wanted to go home. We didn't know any better. And now, we've learned our lesson and it's fine. But, he had those 2 codes and then he continued to keep having codes in the hospital. And then we thought we fixed it with a GJ tube so that he wouldn't be as gassy and wouldn't fart as intensely. Right. And then he went, 2 months without anything and then coded again. And we were just like, typically, like Dr. Prpich would say, these kids, their cartilage, as they get older and stronger and gain weight, their cartilage is going to thicken and get stronger and not collapse as much. But I think what we discovered with time is, sure, it's getting stronger, but he himself is getting stronger. So he himself can bear down harder. Because the codes were getting scared, like they were scary, and it happened so fast. I mean, he would just desat to 0, heart rate would fall to 0, and CPR would start, and it would catch. Like everybody in the PICU was scared of him. Like they'd love him, and they were playing with him, but they knew within seconds he would just it could just happen. And so it got to a point where, I remember Dr. Rexine, all the doctors there are great. We love him. And he called us, 2 a.m. tell us John just needed CPR. He did his little episode again, blah, blah. And he's the one who was like, this PECC surgery, I've heard about this surgeon across the bridge. Like, I think he might be a candidate. And within a week, he transferred across the bridge and Dr. Smithers acted like it was, he needs it. He'd probably be off the vent after, so nonchalant. The kid went from a PEEP of 16 to a PEEP of 8 in like 2 weeks. Yep. And I honestly feel like his life started after that surgery. He was so much more comfortable. 100%. He was way overinflated, but we always just thought that's what he needed to keep his airway open and keep him stable. But after that surgery, it changed everything. And also too, like, that surgery is fairly new. Like it is very new. And there's really only 2 surgeons that are trained adequately to do it in the entire United States. And so I think it's just amazing. And not many people know about it. Like I talk to parents all the time about it and they're like, what? I've never even heard of that. And their doctors have never heard of it.
Yep. Right. No, it's like I said, I mean, and it's one of those surgeries there's an art to it because and for people that don't know, we talk about Malaysia and the cartilage, right? The way the cartilage rings run down the trachea and the bronchi is we say ring, but they're not a ring, right? A ring is a circle. These are more like the letter C, where there's a back wall that's open and there's a strip of muscle that runs down. Yep, exactly. Yeah. Yeah. And when John would bear down or with coughing, that back wall could come in. And if that cartilage is soft or if the shape of the cartilage is just a little wide enough, that back wall can come in completely and completely obstruct the airway. And so what this procedure is now, also people may not realize, but what's running right along the back wall is the esophagus. So that's where our feeding tube, right? That's where we swallow. And so it's right there. So he has to move the esophagus over to the side to then pull that back wall and tether it essentially to the spine. And so it seems like, oh, that sounds like it would be an easy thing, but it's not. And Dr. Smithers is very good at what he does because anytime you're moving and changing the anatomy from the way it's supposed to be in a growing child, there's some risks, right? And so it is one of those procedures that is new and I would also say that it's a procedure that's new in BPD, right? In these in kids like John. I've spoken with Dr. Smithers. They're doing some ongoing trials trying to help follow outcomes because I still struggle with, I mean, John, like I said, was he would just have these spells. It was something had to change, but how do we decide who's a good candidate for that procedure? I wouldn't say, oh, well, it's this. I don't have like exact criteria, right? Or at what age would you consider? It's at this age. I mean, I think it's something that still is in evolution.
Like when is
BPD.
too soon? When
Right.
is too soon to
Yep.
do it? Like I always
Yep.
question, like if we would have done it sooner, would his lungs be healthier now because we weren't overventilating for so long? But I can't ask myself those questions. But I also think that like he recovered so great from the surgery, like within days he was back to normal. And I think that that if we would have done it sooner, it might not have been as great of an outcome either. So
Correct.
It's one of those things. Was John your first patient to get the PECC surgery? Yeah. I mean, it's crazy. It's such a cool procedure.
So he's my first BPD patient to get the PECC surgery. We have, I would probably say, a larger population of kids that have something called a tracheoesophageal fistula, where they have a connection between their airway and their esophagus, because that's a defect that happens very early in development. So their airways and their cartilage are not normal. And so we know that tracheomalacia that those children will have is going to be bad. It's a spectrum, but in general, most of them, it's going to be bad. And especially if they're having symptoms early, that we have to do something. So I've got several tracheoesophageal fistula kids that have had PECC surgeries. I've even had a teenager with asthma that had bad tracheomalacia. She was still 16, 17 and still having bad malacia episodes. That was making it hard for us to figure out what was her asthma versus her tracheomalacia. And so she had a tracheopexy with Dr. Smithers. So but BPD, I mean, it's just a really interesting question, and I'm really, I mean, we're like I said, we're blessed because we have the resource, because we have Dr. Smithers, because there's other centers that even have excellent pediatric surgeons, and although they could consider doing a tracheopexy, I've talked with other centers where they've done them and they've had complications, related to the moving of the esophagus and dysmotility and reflux. And so it's about who's doing the procedure itself too.
Well, when we were in the PICU at Johns Hopkins, I had asked the nurses in the PICU, do you see a lot of these procedures? And they're like, yes, but I would say a lot of them are people flying from other places getting a reconstructive PECC because they did it elsewhere. And so that's why I was like, are you serious? And they're like, yes, it happens all the time, because now that they do it, like these other surgeons, are trying to pick it up as well. But it is, for people who don't know what it is, they go through, so there's a posterior, which is what John had, and there's an anterior. But the posterior, you go through the back, like right here, and you slice open, and then you move the whole esophagus to the side, which if you mess that up, I mean, there's so many nerves there. It is super dangerous. And then you sew the back of the trachea to the spine. So he had 6 stitches in the back of his trachea and then 2 in each bronchi to his spine. And so it's super complex. And then the front is, if you do the one in front, is like, I mean, you have to get cardiac involved. They sew it to the sternum. They have to move everything out of the way. I mean, it's an incredible procedure, but there's the post-op is what's really important too, is managing the post-op with the chest tubes and stuff. And he is just the best of the best. Him and his team are incredible. And so the other thing too is, like you said, you have other patients who have this procedure, but they're a lot more stable, right? Like
they're older, bigger, right? For sure.
Exactly. So BPD kids are not the most stable kids, and they love to give you a run for their money, and they don't do well in procedures. They don't do well on their, like in weird positions. And so he kind of warned us beforehand that in anesthesia warned us too, that with a lot of these BPD cases, they have to take breaks, and it's a very long procedure because they get so unstable, and they have to move them and then like pause and whatnot. And so that's also the other thing is for you, is like, at what point with these kids is it worth the risk of the surgery too? Like, is it going to be beneficial? But it's a great, I mean, I've met one mom online who was a grandma, actually reached out to me, and her grandson has a type of dwarfism, but because of that, he has like the airway collapse and they couldn't ventilate him. And they were in, I think, Missouri, they're in Missouri, kind of in the middle of nowhere. And the hospital basically was like, you need to trach him. And then they trached him, and he was doing awful, and they couldn't get a long enough trach to keep it open. And they kind of just said, like, put him on, hospice or bring him home in comfort care. And I said, well, have you ever heard of a PECC surgery? And they had never heard of it. And so I said, reach out to Dr. Smithers, and so they called John's, they got in touch right away. They flew him down a week later. He ended up getting a posterior anterior pexy done.
Whoa.
He was there for 2 months,
Yeah.
went home. He's not even on oxygen anymore.
Yeah, right.
Living a normal life.
Yeah.
And it's just, it's incredible what he has created with this surgery.
Yeah.
It's wild.
No, I mean, it's something that I would say, remember, I didn't say dates, but, I was back, in fellowship, back in 2007, 2008. I mean, it was a long time ago. And there wasn't even a procedure. So we, our concept of what we do with tracheomalacia was just sort of, it's a problem. You just got to push through it. You just got to deal with it. You got to come up with other solutions, right? I would say that there's been a lot of work, and it's not been very successful at what we call airway stents, right? So in the adult world, for lung cancer or other surgeries, they'll do stenting where they put in an artificial stent to help open the airway. But growing airways do not like when you put something that's not part of their airway into the airway, and it causes more problems. And so the world of airway stenting in these types of situations was probably where people went first as we were thinking about ways to deal with life-threatening tracheomalacia, and it didn't go very well at all. And so this is definitely a newer answer to a problem that we've had to deal with for a very long time. And it was one of those problems that I feel like we kind of got like this sort of attitude of, it's Malaysia. What are you going to do? Right. And what John taught me was, you can do a lot, and the difference. I mean, I always joke, and I've joked with you that I don't want to give a timeline until we're there and we're successful, and I'm not going to do it when it's recorded. but I think that surgery shaved a significant amount of time that he's going to be on the ventilator off of his time on the ventilator. Right? I'm not going to say a number, but it's significant.
I think that he could get his trach out at least by the age of 4 or 5, in my opinion. Versus, who knows how long. We're going in May 13th is our appointment, and we're on CPAP 24 hours. Not 24 hours. We're on CPAP all day, awake hours, and we're hopefully going to start sprinting soon. Which I don't think, if he had the surgery, who knows? He could still be in the hospital. With how I wasn't letting him go home until he was event free for a long time. So
it was so scary, right? But then that was the scary part too, is that even though you'd be event free, these events were random. So
random. Yeah.
So you think, okay, great. It's been 3 weeks. It's been, but then you just look at you and laugh.
We went 2 months, right. 2 months without a code. And they were talking about, okay, another month maybe. And then we got the call at 2 a.m. and I was like, this little boy.
And we know, and we've all heard, and we've lived through, horrible experiences of children that go home and we're one code away from a horrible outcome, So these events are severe. They're significant, right? They're not to be taken lightly. And I think when you walk that road and you have one of those, especially at home, and you come through the other side, it's very right to be nervous because you realize how, you're at home and you feel like you're at home and great, everything is stable. But not.
Dr. G always said it's good to have a healthy sense of fear. Like, it's healthy to have a decent amount of fear all the time. Like, it's exhausting, but it's for parents like us. Like, if you ever let go of that fear, then you get too comfortable. Like, you always need to be ready, because even if they're stable for months with a trach or BPD, things can just happen so fast, and all it takes is 30 seconds. So it's good to be trained, and that's why
be scared.
I try now to share as much as I can online, because to be honest, like, before John got a trach, I didn't know anything about trachs. I thought they were just the old smokers who, had them, and you don't know anything about it. And so it's so scary to you, and there's nothing hopeful about it. So that's why I share this journey, because I want people to see John and see him living a totally normal life, and that your kid will too. And, just how to train properly, how to be ready to go home, how to be prepared for emergencies, because the hospital can train you and they can do a trach class and go over bagging and CPR, but they've never lived it. They don't know what it's like to use a tank of oxygen at home and not have a code button to push and have people running. So
Right.
that's
Right.
why I'm really trying to help as many parents, because we were just ignorance is bliss when we brought him home, which is so
No.
normal. Like, you just want your
It
baby home.
100%, right? And I think, I mean, what you're doing now and what you've done and how you've helped us even tweak our discharge process has been amazing, and is needed because, on average, actually, on average, about 200 kids a year go home that are mechanically dependent, that are technologically dependent, right? That's not, if you think about how many kids going home from the hospital, that's not a large number. So depending on where you're at or what community, you may not have easy access to, a wealth of other moms to talk to in your community. And so that's where having, things like this, having podcasts and having video and being able to see, how other people live their life is huge for parents and for families that that may not live in a large city, or may not live in an area where they have access to that. But even you've helped us work through some of our scenarios at discharge and some of our sort of kind of simulation scenarios where you would say, well, yeah, what if you don't have the other person with you and you've got to deal with the oxygen tank and the bag and this and yeah, you're running a simulation with mom and dad, but you need to do one where dad's not there because you don't really know when that event is going to happen, and it's better to plan for the worst and how do I run this? What normally should be 4 sets of hands to only 2 sets of hands kind of a thing, right? I mean, and so that's been very helpful for us as well, to help with some of that, discharge planning, because it's one bad event at home away from a horrible outcome.
Yeah. And we unfortunately have seen that. And
Mm-hmm.
I think that's what's made it even more real. And yeah, I mean, after his second code at home, I remember we were in the hospital and I was talking to one of the RTs. And I think I had just spoken to you too. And you were like, well, write it down or something like that. Or write
Right.
what you would recommend. And I said, okay. And I got 3 pieces of white paper, front and back, all of them, of just different things that you need to go over and teach these people. And I think I said to the lady when I handed it to her, I was like, I don't want to scare parents, but you have to instill a sense of fear of it's not that these aren't these are going to happen. Some of these things are going to happen. Maybe not all of these incidents, but I would rather be 110% prepared than 50% prepared. And,
100%.
You're not always going to have a second hand at home with you. And if you do, one's usually sleeping. And so you have to start the process beforehand. And yeah, it's definitely two. Okay. So this is one of my questions later on my thing, but I'll go ahead and ask you now. I don't know if this is just a correlation from our hospital, but because more and more 23 and 24 weekers and some 22 weekers are now able to live over these past, especially I'd say 5 years, it's really kind of started. Because of that, are we seeing more trach kids, or is this just a correlation with at our so before John was born, there was only one that got a trach right before him, but before that there was no one for 2 years. They kind of told us no one for a while, and that had a trach. And so it was weird to me when they would always push a trach it was common. I'd be like, well, when was your last one? They're like, oh, we haven't had one in 1 or 2 years. And now John got a trach, and then there's 4 kids after him that have since gotten a trach, that I've connected with. Is that just coincidence here, or is it becoming more common now with these kids being able to be saved?
Right. I mean, I think it's like all things, right? It's multifactorial. One of the things that was eye-opening that I think skewed everything was COVID, and the lockdown kind of skewed things a little bit, right? So there was a period where, there really wasn't, I mean, we didn't have some of these micro preemies being born in the hospital. I mean, just for whatever reason, there was a bit of a pause because of COVID and because of lockdown, sort of changed a little bit of that scenario. We also went through kind of a period, a little bit of so I guess one thing I say is it feels like it comes in waves where you'll have, kind of a period where you have a lot of kids that are more severe and they have trachs and vents, and then you'll have a period where it's dry. Just specific to our program, we had a bit of a change because our high risk maternal fetal sort of OB group shifted and moved away / got let go from the hospital, and that really did change how many of our really high risk moms were coming in and how many sort of micro preemies were getting delivered. And so that definitely changed things for a period as well. For better, for worse. It's so there's so many factors that sometimes will play into when and why we'll have these moms and why we'll have children born so early. I would say though that globally over the years and years and years and years, that yes, we are saving and we are more aggressive with earlier kind of earlier gestations, and so that does change things as well. But it's an interesting kind of observation that has multiple reasons.
Okay. Because I've been wondering about that, because I just feel like I keep seeing, and it could be because I have such a skewed, my community online is all trach parents, or like new trach parents reaching out to me. But I just feel like it's just so many more and more. And just locally, I've had so many local parents reach out to me that their kids are now getting trachs. And because on anybody gets a trach at St. Joe's or whatever, the nurses I'm always like, give them my information. And so I, talk to them and help them through it. So, but it just feels like it's been so many recently. And I'm like, it's probably a coincidence, but I didn't know if it had anything to do with the fact that these kids can just be saved now.
To some degree, yeah. And I think just to some degree, like I said, some of the things that procedurally and just in terms of what moms are at St. Joe's now compared to maybe a couple of years ago, there was a kind of a little bit of a shift in that sense. But then also, yes, you live in a little bit of a skewed world now. Welcome to this skewed world. When people seek you out because you're so amazing. The same thing, like I tell that to families, like I live in a skewed world. I don't see normal children that don't have lung disease, because why would they come see me? So in my world, everyone has some lung disease. So it changes your perspective a little bit on life.
Yeah. But that's, so I tell myself, like, in my world, in my mind is, I don't hope that there's this, that sounds really weird. How do I want to explain this? I want more and more of these 23 weekers to make it and have good outcomes, because, when John was born, there was like 4 other 23 weekers born around the same couple of months. And he was the only one to like make it out because, neck and other things pop in very quickly. But, I just want to share this community and share more moms with other moms, because I want people to understand, like, I don't know, just bring more awareness to tracheostomies and what BPD is, and that it's not forever either. And that's the other thing is people see a kid with a trach and they think that it's forever. And, some of these kids it is, and who cares? It's a trach, it's really not a big deal. But it's so funny saying this because, me 2 years ago, would never believed it. But I also didn't have any resources then. I would, go on YouTube and look up trach, pediatric trach, and there was one video of like some hospital doing a demonstration on a doll. Like that was it. And there wasn't many people on social media. And so that's why I think, doing like an episode like this with you explaining it and just like in like, normal human terms, not like intimidating doctor, because sometimes when you're in a room with a bunch of doctors, it's just so overwhelming when they're trying to explain things to you or to family members. When you try to explain to your own family and friends what the trach is or BPD and stuff, is just, they just can't catch on. So,
well, and one of the things that I say frequently is I say words matter. And so sometimes it's not just because you think you're delivering the information to a mom or to a family, that doesn't always mean that you successfully delivered that information to the mom or to that family. And so the words that we choose, the way that we deliver those words, and sometimes even the time frame over which we deliver those words really can make a difference. And it doesn't matter if in my mind the content, like what I wanted to say, even if it came out of my mouth, if it wasn't registered and understood by the mom, then it was pointless. Then I was not successful, because it's not so much because I said it, it's you need to understand it so that we can continue to have a dialogue and make informed, this idea that we talk about, an informed decision. An informed decision means that you as the mom are making that decision in an informed way, meaning understanding in your heart. Because like we said at the beginning, the last thing we would ever want, and we should ever want, is for a mom to regret a decision. Now, I mean, we're not 100% perfect, but as best as we can, we want to make sure that you as a family, right? Because it's more than just a mom too sometimes, but that you guys as a family feel that you're making what is the best decision for the child. And that sounds like a simple statement, but it's not. Because there's so many competing factors, and so the way that we deliver that information, and right, I mean, I can say it and deliver it as best as I can, but you, once again, back to the resource that you've been to other families, them being able to see what life is like, not from the medical side, but from the mom side, with a medically complex child, with a technologically dependent child at home, is so huge compared to, it doesn't matter what I say sometimes. I mean, just having that lived experience, and for them to be able to see that lived experience makes a huge difference. It really, really does.
Yeah, it really does. It makes such a difference. I mean, honestly, like, no offense, but like, I talked to you and I'd be comforted, but then I'd talk to like 4 different moms whose kid got the trach, 6 months prior, and now they're at home thriving. That, to me, made more of a
100%.
Difference, because it was more relatable, more realistic than, a doctor who deals with BPD on a daily basis.
Absolutely.
So it's, the medical team is really important, but your community is also super important. All right, so let's move. Okay. This is actually a question that I have, because I don't even think I've really ever asked this question or talked about this, and a couple moms asked me about this to ask you. So once you have BPD, do you outgrow it? Like, I mean, eventually, or does it turn into asthma, or, will they ever be able to be like play hockey, or will their lungs be able to not probably handle that? Like, what is, I mean, I know it's so complex, but typically what does it look like for these kids as they grow?
Yeah, no, that's an important question. And of course, a very common one. So right. So we talked about that lung development, and that, and part of why I bring that into the conversation is so that then we understand that yes, we've got years of adding back and years of lung development ahead of us, which is thankfully in our to our advantage. All of us have a period as we grow and get bigger where we have an improvement in lung function, and then we reach sort of a period where it's sort of static, and then there's a normal decline in lung function. Which is just normal and kind of physiologic. We're understanding now, as we have more of these children, born early, and not even 22, 23 weekers, but even just later, that trajectory looks like it may be different. And so our kids that are born premature, even though we can see a huge quality in life, there does seem to be sort of a change in terms of what their trajectory of their lung disease looks like for their lifetime. Now, what that means clinically is different, right? So yeah, are they, if you were to look at, and this is the whole population, because there's always individual, kind of variability, but, are they going to be, competing in the Olympics in an ultra endurance sport? That's going to be a challenge, right? I mean, but are they going to be able to play hockey with their friends or play basketball with their friends? Yeah, the quality of life, from a respiratory standpoint is good, but it's different, than somebody who doesn't have BPD. But it's not. We shouldn't look at it as something that's life limiting, or something that really is going to be limiting in terms of their long term outcome. But there is a different trajectory in terms of lung function over time. But once again, I mean, we don't have somebody who's 75 that was born at micropreemie, right? So
I mean, we only have like mid-teenagers at this point.
Correct.
I mean, maybe not even. I mean, 23 weekers have only been saved for 10 years, maybe max. I mean, I don't.
Yep. So we're it's an area that we're learning more about in terms of what that trajectory looks like. I think one of the things that we haven't talked about, but other comorbidities that we run into, along with, we talked about BPD and lung disease and pulmonary hypertension. But then there's also probably the other big comorbidity, the other big kind of condition that can affect our children that are born premature is neurologic, right? So our kids that part of their time in the NICU ended up with what we call an intraventricular hemorrhage. So a bleed into the middle part of their brain puts them at increased risk for some what we sort of neurodevelopmental outcomes. So things like cerebral palsy, things like developmental delay, and just neurocognitive delays, muscle spasticity. And so those aspects are especially in our micro preemies, are more common, and those are going to impact quality of life and often impact more so than the respiratory side of things, right? So their ability to do activities based on that spasticity or based on what sort of other neuro kind of developmental delays they may have. But so that's where you start to get the variability is along with their lung disease, what else did their prematurity leave them with regard to developmental delay or cerebral palsy or those other neurobehavioral conditions. We know. So the other thing that you had asked about asthma, right? So a larger number of these kids that come out have a version of asthma. They have this increased airways reactivity that they deal with that can be triggered by exercise. It certainly can be triggered by viruses. Often we're on inhaled medicines that help with inflammation. We're on inhaled medicines to prevent bronchospasm. A lot of those kids, as they get older, that becomes less of a problem as well. But a lot of kids, it may be part of who they are as well. And it seems like it's part of their prematurity. It's hard to control for all those different variables. But if they had not been born premature, they wouldn't have had that aspect to their airway function. So that airways reactivity and that sort of asthma-like sort of response to different triggers in their environment is more common as as well. And so that may impact quality of life also.
What about so John's super immunocompromised, like for many reasons, because he's lived in a bubble for so long, but also because if he gets sick with his lungs, how sick they are could be really bad. At what point, is he going to be immunocompromised till he's 10? Is he always going to be immunocompromised, or is it just going to be as we get through every virus season and he has more exposure and gets through more things on his own? Does that build up his immune system and his lungs eventually will be at a better spot? Is that kind of how it works?
Yes. So there definitely is a component where, because you're right, early in life, the first years, and we tend to protect them. And so we don't want them, because the sequelae, what happens with those viruses and what happens after those viruses are so detrimental that we just don't want them exposed, right? So we use things like Synagis or Beyfortus, these medicines to prevent RSV. We try to keep them out of daycare, keep them out of, exposure to other kids. But we realized, and we learned this during COVID and the lockdown, there's an immune education that goes along with being in daycare, being around other kids. And so they're a little delayed in terms of some of that immune education. What happens as they get older is they get stronger. And it seems sort of like, well, that's an easy answer, but airways, right, as they grow in height, their airways grow in diameter. But also the nature of their muscles, the nature of the muscles in the diaphragm, the nature and the muscles in between the ribs and their chest wall size and shape change as they get older. That allows them to handle these respiratory illnesses much better. Their cough becomes much more effective. When they have a respiratory virus and there's increased secretions in their airway, it's much less of a big deal because they're able to cough and clear these mucus plugs, and they're able to overcome them. And to be honest, as we get to that point and have the tracheostomy out, now a mucus plug is able to be handled better because their cough is more effective because we're not bypassing their vocal cords, right? When that trach is in, it makes their cough less effective because they can't build up pressure in the same way that you or I build up pressure without a tracheostomy in order to effectively cough and clear secretion. So we get older, we get bigger, we get stronger, we have a trach that's no longer present, so we can cough more effectively. And then we handle these viruses better, which then contribute to our own immune education. So it all sort of piggybacks off each other and gets better over time.
It's so reassuring to hear that. When you were talking about brain bleeds and stuff like that.
Mhm.
So we always felt so blessed
Mhm.
because you can, not that you can, I mean, you can kind of heal lungs, but with time,
Mhm.
lungs can regrow, and
Yep.
it's much easier to fix lungs than to fix
Yes.
brain.
100%.
And and he never had like stomach, like neck also was the scariest thing in the
Mhm.
NICU too. But I was always like just so grateful. You know what? Lungs we can fix, and it's not going to affect him long term. And and so we were always really grateful that we just had lungs to deal with, because he didn't have any brain bleeds, which is like unheard of for 23
Right.
weekers, which
No,
is
it's much more common in that population, right? And I'll
yeah,
tell parents that. I'm like, look, I don't want to, words matter, and we want to be optimistic. So, but I'll tell, when I have a family like John where they've made it through without IVH, that's one of my sort of like hurrah moments. And I don't want to say this as if in the families that don't have that experience, because it, that's what they have to deal with. Those are the challenges on their plate. But if we can make it through without the IVH, we can make it through without spastic cerebral palsy. I mean, you're 100% right. We can grow new lung. We can add to lung function, lung development. But the brain is the brain, and that is still really the most important organ that's in charge of those aspects of what we would typically consider quality of life, in terms of communication, in terms of swallowing, in terms of physical activity.
yeah, exactly. Yeah. So I always have to look at, you live in the ICU for so long, you always see somebody else has it worse, and so you just kind of
Mm-hmm.
become so grateful for
Yes.
what you have, even though, someone might look at you and be like, oh my God, that's, awful. But it's like, sure, it's not ideal, but we are very blessed. The kid is
Mm-hmm.
Dr. Prpich, he's pulling his vent tubing off.
Yeah.
He now thinks it's funny to pull his trach out. Like, he's figured out how to
Yes.
pull the trach out, and he thinks it's funny, and he laughs while it's
Of
out, and
course he
we're
does, because to
frantic.
him it is funny, because he gets attention, and he's a riot, right? But these are the things that we look for. This is personality, right? This is
He is
this is
full
the
of
fun.
personality.
Mm-hmm.
Yeah. It's
Yep.
it's
100.
cool to see. It's definitely, we are very excited to get him off of the vent. I always tell people
Mm-hmm.
now, like, the trach is easy. Like, the trach on
Yep.
its own, so easy. It's the vent that's the annoying part once they start moving. We have to put his vent in a little shopping cart, and it has to follow him everywhere because
Yeah.
he's on the
Right.
move, and he doesn't know any different. He thinks that's just him, like part of him. So it goes
Yep.
where he goes, and if he
Yep.
can't get to where he goes and pulls himself
And he's
off.
like, fine. So,
Yeah.
and that, back to when I first, like, why I love taking care of kids is because an adult can't get past their disease, their condition, their state, what's put in front of them on their plate. They don't get past it, and so they don't live their life what they have in front of them. But children don't care. Children are going to find a way to play. They're going to find a way to make the best of it. They're going to find a way to adapt to what's in front of
Yes.
them and still be children. And that is a life lesson that I take from each and every one of my kids. Don't sweat the small stuff and find a way to live your life, because they will teach you that in spades, and it's amazing. It's amazing.
It's, the way that he adapts, he first learned to crawl like a normal baby.
Mm-hmm.
And then within
Yep.
a week, he figured out that his knees being on the ground would get stuck on his vent. Like, he would get his vent stuck on the knees. So he was like, I can't do this. So he learned to like bear crawl. So he crawls
Mm-hmm.
with butt all the way up, no knees.
Yep.
And
Yep.
that's more of a workout. And that's what he does. And he's learned
Right.
to like do these arabesque kicks, but he
Mm-hmm.
does it to get over his vent. Like, he
Mm-hmm.
knows
Get
how to
over the
walk
tubing,
around
right?
the vent. Yeah. And
Yep.
like, he'll roam the couch, and he knows that if he moves his feet a certain way, he can get the tubing around him. And I'm like, that is so smart that you've just figured that out. But he doesn't know any different. And I always remind myself, like, on days when I feel bad for him that he can't just like be free and go wherever he wants, I am always like, he doesn't know any different. He doesn't
Right.
know that he's missing out on anything.
No,
He's living
no
his
clue.
best life. And so I might be sitting there and having a pity party, being like, this isn't, what I expected my child to be, looking
Right.
like at 2. But he's looking at me and smiling, being like, come on, Mom, let's go run around. Like, follow me with my vent. He doesn't know any different. So
100%.
it's that, I feel like if I went into the medical world, it would have to be with kids, because I agree. I don't know how anyone does adults. No offense to those
No,
people, but
my wife. So I met my wife in residency. She was one of the pediatric hematology oncology nurses, right? So she, and she tells very similar stories from the cancer wards, from these kids, just running around, or on their tricycle with their IV pole with chemotherapy, just tearing around the unit, having a blast. And that's not what you see when you go to the adult, oncology floor. And so it's eye opening, but in such a good way, about the way we're supposed to be approaching life. 100%.
exactly.
One thing I want to mention, and I think we may end up splitting this podcast into multiple podcasts, because my phone is at 1%.
Okay, that sounds good. We can do that.
I don't know how to. We've also been talking for, I think, an hour and a half. I think we could eat.
Yeah.
I think we could do a second and a third version of these.
Yes, 100%. What's your? Do you have one more thing to say, or is your phone about to die?
Well, I've just been looking at the number, going, oh man. Because I feel like there's so much for us to talk about.
I know. Well, we covered a lot of BPD. I mean, my next questions really would be, which we can do a whole episode on it, is a lot of people want to know why you prefer CPAP trials.
Oh, right. Yeah,
over just going straight to sprinting. So we can do an episode on that. Also, traveling with event and trach, what's safe, what do you recommend, certain area like the beach, is that safe? Like just different things like that.
Yeah.
I also want to talk about why you've mentioned to me before, there's such a decline in pediatric pulmonologists coming out of school, and what that and he's gone. I knew his phone was going to die. All right. So like he said, we are going to make this a multiple part episode. So that was the first episode. And then we will do a next one with those questions I just mentioned, and then probably another one, because as you can tell, Dr. Prpich and I can talk forever. And there's just so much information to share and go over about these kids and their BPD and their issues and all the complexities that come with it, because like I said, no cases are the same. So that was part one with Dr. John Prpich, who is the best pulmonologist in the entire world. And him and his team are amazing. His nurse practitioner, who we work with a lot, shout out to her. She's the best. We love them. We go in a couple weeks to start sprinting. So we'll keep you updated on that. But we will catch you on the next episode. Hopefully we can get it scheduled shortly-ish so that you don't have to wait too long for it. But thank you for being here today on the Daily Vent, and I hope you